The current model of heart disease focuses on several risk factors, often referred to as traditional risk factors, such as high cholesterol, high blood pressure, smoking, diabetes, family history of heart disease, obesity, and age. In 2011, a study published in the Journal of the American Medical Association came up with a surprising result in relation to these risk factors. The researchers looked at 5 of the traditional risk factors in relation to survival after a first heart attack. We might expect to find that those people who didn't survive a first heart attack had more of the traditional risk factors. However, the reverse was true. The more risk factors the person had, the more likely they were to survive a first heart attack. This association between a higher number of risk factors and survival persisted even after adjusting for age and for other clinical factors.
So all these factors correlated with heart disease. If they have those factors high, they're protected. They will live longer. So this is something to me that people should be studying. I mean, it's like, what is wrong? If we've got a model that in these situations is backwards.
That's a complicated issue for several reasons. And they're not dissimilar to what has happened with the cholesterol story.
Some of them do work. Age is probably the most important risk factor, but you can't do anything about that. Being male does carry a greater risk than being female. Smoking is a risk factor. Having diabetes. So some of these are definitely, they're correct. But the ones that most people probably hear about, your cholesterol level, your blood pressure, they don't fit.
What is considered to be normal cholesterol has progressively gone down. Taking some more drugs. The exact same thing is true for hypertension. 120 over 80 used to be considered normal. Now it's pre-hypertension. So the first thing you have to ask yourself is, well, when you talk about hypertension, what are you talking about? What do you consider normal?
We know there are many papers showing positive association between blood pressure and coronary heart disease. So then people interpret that the hypertension is a risk factor. The hypertension could be the consequence of the progress of atherosclerosis. By raising blood pressure, our body are keeping to supply nutrients and oxygen to the peripheral tissue.
Blood pressure is kind of like cholesterol. Is very often it's not the problem itself, it's the body's response to the problem. And the purpose of a raised blood pressure is to supply more blood to areas that might need it.
If you lower blood pressure, you will lower your risk for stroke. But you will not prospectively lower your chances of getting a heart attack or developing atherosclerosis.
I think there's almost just increase life expectancy by using blood pressure lowering drugs.
Well, everyone thinks that obesity is about how much fat you carry. And at least from a definition standpoint, that makes sense because we define obesity on the basis of this thing called BMI, body mass index, which is how much do you weigh versus how tall you are. So in that sense, they're right. The question is that definition even appropriate? When you stand on the scale, what are you measuring? Well, you're measuring 4 compartments at once. You're measuring bone. You're measuring muscle. You're measuring subcutaneous or big butt fat. And then finally, the visceral fat, the belly fat. Well, it turns out that visceral fat is only 4 to 6% of your total body weight. So when you stand on the scale, what are you measuring? You don't know. You can't know. So the concept of using BMI as a method for determining obesity and risk for disease makes perfect sense in populations where everything regresses to the mean. But for individuals, BMI is, for lack of a better word, it's garbage.
The biggest change in my lifetime looking after people is that when I came into medicine, the patient came to us with a complaint or a problem, and we tried to sort it out. In the 1960s, 70s, 80s, gradually the whole game changed, that in such a way that we were trying to treat people to stop them getting problems, to stop them getting their heart attacks and their strokes in particular. So you got the matter of treating risk.
If you've heard it once from your doctor, you've probably heard it 1,000 times. Know your numbers, blood pressure, your BMI, and how about your bad cholesterol level?
Okay, but if you're treating risk, there are certain things you need to know. What is the risk? What is the benefit of treatment? And who benefits from that treatment?
Okay, prediction is like stock market. You're going to get an actuarial finance guy who'll sit and predict here what's going to happen in the stock market. That pooled estimate of actuarial futuring in patient doesn't apply. The reason for that, human beings aren't numbers.
Despite the problems with the current risk factor-based approach, it is this model that is used by doctors all over the world as the primary tool to decide who should be medicated.
In an important medical story for Americans tonight, heart doctors are putting out controversial new guidelines for preventing heart disease.
So rather than adjusting the statin dose to reach a certain cholesterol level, the panel now advises doctors to prescribe either a moderate or high dose depending upon the patient's risk factors for cardiovascular disease.
Statins are already taken by millions of people. Their use has quadrupled in the past decade, with 60 million prescriptions a year in England now. GPs currently offer statins to patients who have a 20% risk of a heart attack or stroke in the next 10 years. NICE wants to lower the threshold to 10%, so many more people will end up taking statins.
So is that a form of prevention?
Yeah, that's quite correct, Matt. What's worked out through these calculators, which we've been using in Australia now for a number of years, is adding up all those risk factors, as was mentioned in the previous report, to determine what is your risk of having a heart attack or a stroke in the next 5 years.
We have an update tonight on last week's story about the new guidelines for cholesterol and who should take statins to reduce the risk of heart disease. The guidelines were put out by the American Heart Association and the American College of Cardiology, but tonight there are questions about the formula or the calculator that they used.
Paul Ritger and Nancy Cook of Brigham and Women's Hospital looked at published studies of patients with cardiovascular disease and say the new calculator significantly overestimates the risk. The calculator may suggest statin treatment for about twice as many middle-aged Americans as actually may significantly benefit from it.
One of the recent articles showed that 12 out of the 15 panel group are affiliated with the industry.
The drug industry buys influential doctors, and these doctors are allowed to sit in guideline committees, although most countries have laws of public administration that says otherwise. We also accept it in my country, so I have complained to the Danish Ombudsman about this, that our National Board of Health is not living up to our law of public administration because they use these conflicted doctors, and the guidelines get influenced by having conflicted doctors sitting there. And then you have a big problem in general practice because they are supposed to follow these guidelines.
The guideline of Atherosclerosis Society in Japan, published in 2012. Okay. At first, I looked for information of COI. I was very much disappointed. They didn't write it at all. Okay, next year. This is a sister book of this one. Okay, and this is also published from JAS, and it says treatment guide for dyslipidemia. Okay, I tried to find COI information again. Yes, I found it. The very first page, yeah, they wrote COI information here. Okay, this one is just for the rules of disclosing COI. And this part is just list of Japanese pharmaceutical companies and medical equipment companies and publishers. Where are authors of this guideline? Nobody is here. It's the list of companies. Is this COI information? I don't think so. So we do not understand which researcher is getting fund of money or something from which company. No, nothing at all. Just a list of companies. And it says COI. Well, you can laugh it. That's at this. But to be honest, I'm not sure to laugh at it or to cry.
Studies have shown that if you ask a doctor to estimate how much benefit they're giving a patient by giving them a certain treatment for blood pressure or cholesterol or blood glucose, they will overestimate. If you actually look at the real figures in terms of the number of people whose lives will be affected by this treatment, you come up with answers where many people in the street would say, well, okay, fair enough, but forget it. I'm not interested in that level of risk.
I'm 61. I've got a predicted risk of having a heart attack over the next 10 years of about 10%, which puts me in the frame now for potentially needing to take or being offered a statin. So at that sort of level, a 10% risk over 10 years, 2 people are going to benefit out of 100, 98 will not get any benefit. So in terms of the amount of treatment you have to mete out to a population for the return that you get in terms of events avoided is small, but it's almost certainly not a fluke, not due to chance, it's a real effect.
It is not the cholesterol lowering effect, because the statin drugs have many other effects. For instance, they inhibit the coagulation system. No trial has ever shown an association between the degree of cholesterol lowering and the effect on the treatment. I mean, if high cholesterol was the real cause, then those people whose cholesterol went down very much should have more benefit than those whose cholesterol was unchanged. But this is not the case. The effect is the same whether they have normal or very high cholesterol.
The 2% of people who will benefit specifically refers to benefits associated with cardiovascular disease. However, none of the clinical trials done on statins have shown any benefit in terms of deaths from all causes. In other words, people do not live any longer when they take a statin as a preventative measure. This indicates that the unknown adverse effects of the statin are counteracting the small cardiovascular benefit. Although the individual clinical trials have included thousands of people, there has been a suggestion that larger data sets are required in order to demonstrate an increase in life expectancy.
One of the difficulties is that when you do primary prevention trials, not many people die, okay? Which means that you need big numbers to detect small effects. Any individual trial is bound by what is a reasonable amount of money, time, energy, patience to conduct. And that is the virtue of systematic reviews, where you put lots of trials together.
Almost all of the systematic reviews of statins have also failed to show any increase in life expectancy when the medication is given to people who do not have heart disease. In 2011, Professor Ebrahim and colleagues published a Cochrane review of statins, which was one of these systematic reviews. Cochrane is one of the most respected research organizations in the world. The organization itself is free from commercial sponsorship. After completing the Cochrane review, Professor Ebrahim stated, "If you look at the hard endpoints of all deaths and coronary deaths, the effects are consistent with both benefit and with the play of chance. The absolute benefits are really rather small. 1,000 people have to be treated for 1 year to prevent 1 death. It means a lot of people have to be treated to gain this small benefit. As we don't know the harms, it seems wrong-minded to me to treat everyone with a statin. Then, in 2013, the Cochrane Review was updated, and this time the authors were in favor of the widespread use of statins, concluding reductions in all-cause mortality, major vascular events, and revascularizations were found with no excess of adverse events. The authors also said that the widespread use of statins is likely to be cost-effective. So, why the change of heart?
I think you're misreading the earlier version. There is no doubt that statins had beneficial effects. The concerns we had was that at that time, the reporting of the adverse unintended consequences of statins was poor, which made it difficult in the primary prevention setting to be fulsome support for their use, and we said they should be used with some caution. If you're looking at the overall total mortality, and that's what life expectancy is giving you, a translated estimate of total mortality, you're seeing a small, but, and again, probably real effect, but a small effect because of the many other causes that are involved. If you look at it in terms of death rates, all-cause mortality rates, there's been some confusion about this in the literature recently. My reading of the trials is that people on statins, the all-cause mortality rates are lower in people on statins.
And the best estimate that we have, again, what are the actual numbers? What was the absolute risk reduction in all-cause mortality? Or how much longer can someone expect to live in primary prevention by taking statins?
Well, the data weren't presented in that sort of way. We see actually a small reduction in all-cause mortality on statins, which is consistent with the reduction in the coronary heart disease events that have been reduced.
So if statins in primary prevention do increase life expectancy, where does that evidence come from?
Well, we can't get strong estimates of life expectancy with the trials because they're short. So we can extrapolate from those. But essentially, we've got trials that run for 5, 7, 10 years. We've got long-term follow-ups on some of the trials. And the benefits of the statins seem to be prolonged.
But from what report, what trial, where is the actual evidence? Because you've said that they do increase life expectancy. So what reference, what report can someone look at to?
I think the best summary estimates still come from the cholesterol treatment trialists collaboration report, the 2012 Lancet report.
Now, they did a review in 2012, which apparently turned everything on its head and said that, yes, statins were beneficial in primary prevention and at very low levels of risk. At that point, all the other groups in the world, even the Cochrane collaboration, who'd said primary prevention is pointless, the benefits are minute. Then the CTT came out, where the Cochrane collaboration changed their minds, completely 180 degrees shift. Now, I have concerns about the CTT research because, firstly, they won't show their data to anyone.
Well, we have indeed seen a small effect on people who already have had a heart attack. But I am a little skeptical to the results because it is not possible to get access to the primary data.
They've signed agreements with pharmaceutical companies that they won't release the data. So we're relying on them alone.
What we now know from experience gained over the last 20 years or so is that it would be a much better place for the industry and for patients and for those of us trying to make sense of the data if all that data were available.
And all these trials have been performed and paid by the drug industry, in the same industry that produce the drug they are testing on patients. It's not a good idea.
So we're essentially relying on the pharmaceutical companies to have provided all the data required and for the CTT to have done an analysis on that, upon which rests all of the advice for the use of statins around the world. I don't think that's a good situation to be in. because the cholesterol trialist collaboration is also a part of another unit called the CTSU in Oxford, which is the Clinical Trials Service Unit, which essentially runs multi-million pound studies on behalf of the pharmaceutical industry. So I think there are dangers here of significant conflicts of interest, which have not really been addressed, and I think they ought to be.
95% of research done on statin is funded by the multinational. And that's the problem. A big multinational comes in, spend a couple of billions on a trial, and then tell you that it's good. Nobody trusts that anymore. We've been burned few times to the extent that whatever result any multinational is going to get, we do not trust.
It is a very bizarre situation because if I was accused of something in a court case and I came up in court with 15 meters of documents and told the judge, this is all the evidence there is in my case, and I've collected it myself, please tell me if I'm guilty or not, I might be thrown out of court. But this is the system we have created for the drug industry. And we must think about the fact that the difference between an honest data analysis and a not so honest data analysis can actually be worth billions of dollars or euros on the world market.
Remember, the stock market depends on a lot of this multinational. However, my patients are the most important. I don't care about the stock market. I care about my patient.
The influence of the pharmaceutical companies is everywhere. They have their tentacles everywhere. And they try to, I'm sorry for this expression, but that's true. They try to bribe every type of person they can. And there are examples that they have bribed every type of person there is, including ministers of health. So the money is everywhere. The drug industry systematically buys doctors. They buy their loyalty by putting thousands of them on their advisory boards or as consultants, or they lecture for drug companies, which is also bad because education of doctors should have nothing to do with drug companies. And in this way, they buy loyalty among doctors. So doctors won't protest too much if they are told that they cannot get access to the data they collected themselves in clinical trials and check whether the data analysis performed by the drug companies are okay. There are many, many ways you can look at the same data set, and there are also always uncertainties and ambiguities, and you need to make up your mind. Was this a heart attack or wasn't it a heart attack, and so on? And then you can analyze the data in lots of different ways when you have decided who had an event and who didn't have an event. So it is really possible to massage your data until they tell you what you want to hear. And I have seen that many times over my career, where things that were published in the major journals in this world were simply untrustworthy when we, in rare cases, got access to the data through lawsuits or through drug agencies.
After the first Cochrane review, the authors highlighted these issues concerning the commercial sponsorship of clinical trials, and in a press release stated that all but one of the trials they reviewed were industry-sponsored. The lead researcher, Dr. Fiona Taylor, stated, "We know that industry-sponsored trials are more likely to report favorable results for drugs versus placebos, so we have to be cautious about interpreting these results." However, these concerns seem to have disappeared after the second review, which used even more pharmaceutical company-sponsored data than the first review. We asked Professor Ibrahim if he's concerned about problems associated with the commercial interests.
It's an inevitability that trials are commissioned by pharmaceutical industries, occasionally in partnership with non-commercial sponsors. And I think if you look at the integrity of the research groups that have been doing the trials, it would be hard to imagine that any industry hand had been involved in those analyses. They're not the sort of analyses that come out of anything other than a very skilled academic group of researchers. The Oxford group have invested a lot of time, a lot of money has been spent on setting up that individual patient database with a very large number of randomized trials included in it, industry-sponsored. And I think they've done an incredibly good job of the analysis of that data.
The Clinical Trial Service Unit is run by Professor Sir Rory Collins. Professor Collins has been heavily critical of anyone who questions the benefits of statins. He's also tried to use his influence to have scientific papers that are critical of his research removed from the British Medical Journal. We requested an interview with Professor Collins to discuss the evidence for the widespread use of statins. Initially, Professor Collins agreed to this, then 2 days later declined our invitation. Pharmaceutical companies are not the only sponsors of the Clinical Trial Service Unit. The British Heart Foundation also gives them money. We wanted to ask the British Heart Foundation about their support for the CTSU and the clinical evidence for the widespread use of statins. After a brief exchange of emails, they also declined our invitation to take part.
There is not one single trial that have proven that statin works in primary prevention.
We are all going to die. And if we don't have some certainty that by taking a drug for decades, we will expect to live longer, and when we don't know really what the harms are, because they are always badly reported, then we have a problem.
This kind of guidelines are of the big pharma, by the big pharma, and for the big pharma. It's crazy.